And our next lecture, Dr. Kurt Hecher, he's the chairman of the Department of Obstetric and Fetal Medicine, University Medical Center, Hamburg, and Germany. And his talk will be very interesting, the monitoring of early and late onset of IUGR.
You want the pointer? Okay, so 1 minute, 1 second. Well, thank you very much for the invitation to talk here in Cairo again. It's a great pleasure for me. And I'm going to talk about early and late onset fetal growth restriction. Now, first of all, we have to distinguish between fetal growth restriction and small for gestational age. Small for gestational age is just a small baby, which is with its biometry of the abdominal circumference below the 10th centile. And most of them are constitutionally small fetuses, but not sick fetuses. Versus fetal growth restriction, and we are going to talk about the fetal growth restriction, which is due to impaired placental function and therefore fetal starvation. And you have to differentiate that from sick fetuses in terms of chromosomal abnormalities, genetic syndromes, or fetal infections. Now, if you look at the growth curves here and in comparison to the normal ranges, you can see the blue dots are indicating a small baby with an AC, abdominal circumference, or an estimated fetal weight below the 10th centile. However, yeah, okay. However, as you can see here, no, that's not a pointer. Okay, I do it without it. The blue dots show you a growth which is parallel to the centiles. So this is a small baby, but it is not a flattening of the growth curves. Therefore, it is most likely a constitutionally small baby, whereas the red dots indicate a typical case of early fetal growth restriction, and the orange dots show you a case of late fetal growth restriction, which may even be within the normal values when you do the scan at a more advanced gestational age. As the arrows show, they are within the normal range, but there is a flattening of the growth curves. Therefore, it's very important to have longitudinal assessment of the fetuses. Now, what are the difference between early and late fetal growth restriction? There is nothing dramatically happening on the night from 31 weeks plus 6 days to 32 weeks plus 0 days, because it's a continuous development. But there are different features of early and late fetal growth restriction, and let's have a look at that. In the Delphi consensus, there was an agreement of the criteria of the definition of early and late fetal growth restriction. You can see early fetal growth restriction is an AC or estimated fetal weight below the 3rd centile, or umbilical artery absence or reversal of end-diastolic flow, or estimated fetal weight and AC below the 10th centile in combination with either increased resistance in the uterine artery or increased resistance in the umbilical artery, versus late fetal growth restriction is again estimated fetal weight or AC below the 3rd centile, or at least 2 out of the 3 following parameters, which is below the 10th centile, or in this case, it is again this crossing centiles of more than 2 quartiles in growth centiles, which I have just shown you. And here now, it is the CPR, the cervical-placental ratio, or as we can see, the umbilical cerebral ratio the other way around, which is abnormal in these cases. That's the definition for late fetal growth restriction. Now, what are the main difference between these 2 types of growth restriction? The main clinical challenge is management with early fetal growth restriction and its detection with late onset fetal growth restriction, and then timing of delivery. The prevalence is 30% of all growth restricted babies for early fetal growth restriction, and 70% of growth restricted fetuses show late onset fetal growth restriction. We have talked about the definition of gestational age already. In the ultrasound findings, early fetal growth restricted fetuses are very small usually, and late onset, they are not necessarily too small. As I have shown you, there's just a flattening of the growth curves. Doppler changes are expressed in early fetal growth restriction in the umbilical artery, the middle cerebral artery, and the ductus venosus. We are going to talk about that in a minute. And in late onset, it is mainly cerebral blood flow redistribution. You don't look at the ductus venosus anymore then. Hypertensive disorders of pregnancies are frequent with early fetal growth restriction, and they are not frequent with late fetal growth restriction. And therefore, this is also the picture. You have a mirror picture in the placenta. You see histological abnormalities in early fetal growth restriction quite common, whereas they are less specific in late fetal growth restriction. Perinatal mortality is high in early fetal growth restriction, either intrauterine fetal death or mortality due to a severe premature delivery. And it's low, of course, but there is an increased stillbirth rate in late fetal growth restriction. And of course, there are different types of maternal cardiovascular hemodynamic status at an early and late gestational age. Now, is there intrauterine therapy for early fetal growth restriction? There was this Strider study on sildenafil, and which is a potential agent. It's a phosphodiesterase inhibitor, which may lead to vasodilatation of the uterine vessels, but unfortunately it does not. It has no effect. This study showed no evidence of beneficial effects in terms of prolongation of pregnancy, neonatal survival, morbidity, or fetal-placental perfusion. And the authors concluded that improvement of in utero-placental perfusion in fetal growth could not be shown. There was no effect and no efficacy. And all these randomized studies which look at possible therapy or management of fetal growth restriction, especially early fetal growth restriction, should include long-term follow-up assessment of surviving children. Now, what is the main decision we have to take with early fetal growth restriction? It's to find out and to estimate the best time, the optimal time for delivery of these fetuses to avoid intrauterine fetal death or stillbirth. But not only death, not only mortality is a challenge, but also morbidity. And we have to balance the risks of intrauterine growth restriction versus extreme premature delivery and risks on the basis of premature babies. And you can see here, we all know that there is this, it's not a cutoff, it's also a continuous variable gestational age, but before 32 weeks, the typical risk for prematurity, like respiratory distress, sepsis, intraventricular hemorrhage, are much higher than after 32 weeks. So the main goal is to prolong pregnancy as long as possible before you reach 34 weeks in order to avoid the high risks of prematurity. Now, what are the parameters we look at? It is the umbilical artery, as you can see here. Just by eyeballing, you can see the increase of placental resistance with the highest pathology with zero flow during diastole and reversal of flow in the umbilical artery. The next step is that there is fetal blood flow redistribution. Fetal blood flow redistribution originally was defined as the comparison between the aortic blood flow and the middle cerebral artery. And you can see here in the aorta, there's also end diastolic zero flow, whereas in the middle cerebral artery, there's a huge increase in blood flow due to a decrease of cerebral resistance. Now, this was a slide which is now, well, it's a slide which is already more than 20 years old, and originally it was designed by Enrico Ferrazzo, who just gave a lecture before here. And I'm very grateful for him that he did this slide. And you can see here, this was a management study we did together with Katia Belardo and others, where we looked at early fetal growth restriction and the time sequence of events of deterioration in the Doppler waveforms and in the CTG. The shaded area is the normal area, the normal measurements with plus minus 2 standard deviations. And we have observed them from up to 7 weeks before the indication for delivery. You can see here, umbilical artery PI is high in early fetal growth restriction. Of course, this is the reason for the growth restricted baby. Middle cerebral artery and amniotic fluid index are low, but middle cerebral artery does not help you in early fetal growth restriction because it starts early and it's a compensatory mechanism and it goes on for weeks and there's no change. So if you would take a baby out owing to or on the basis of fetal blood flow redistribution, you would increase iatrogenic severe premature delivery and you would rather damage the baby than help the baby. Whereas ductus venosus PI, the pulsatility of the ductus venosus goes up, and that days before the necessity to deliver, and short-term variation goes down. So those two variables show a mirror image. However, they do not occur similarly or simultaneously in the same fetus. Some of them show the abnormality in the ductus venosus earlier than the short-term variation, the fall in short-term variation, and some of them behave the other way around. Now, this study showed very clearly that perinatal mortality, intrauterine fetal death, and neonatal death was significantly higher, 39%, if both parameters were abnormal, ductus venosus and short-term variation, whereas it was only 7% if both were normal or only one was abnormal. So this study showed you clearly, don't wait until both are abnormal. So let's have a look at the ductus venosus. This is a normal ductus venosus with huge or high, the lowest velocities during the cardiac cycle, but still high velocities during atrial contraction, whereas this is a severely abnormal ductus venosus with reversal of flow during atrial contraction due to increased end diastolic ventricular pressure. And the other parameter, the short-term variation, is something you cannot estimate or you cannot measure just by eyeballing the CTG trace. You can do that with decelerations, of course, but you cannot calculate the short-term variation. You need a computer for that. And this is the system with a computerized CTG. First of all, there's an increase of short-term variation with advancing gestational age. So this is a measurement which is dependent on gestational age, the same as biometry. And we do Doppler, we measure the pulsatility, we measure the fetus, we do biometry. So why should we not measure short-term variation? And this is exactly what the computerized CTG analysis does. And the animal studies in sheep, and then later in human fetuses as well, from Professor Dawes, who was a physiologist in Oxford, and Redman, showed that if short-term variation falls below 3 milliseconds, there's an increased risk for fetal hypoxemia and intrauterine fetal death. Each fetus is its own control, because this is a study with a longitudinal analysis of short-term variation over gestation in individual fetuses. So all these lines are individual fetuses. And as you can see here, they don't jump up and down with the short-term variation. Each fetus has its own curve with an increase of short-term variation. So therefore, we have to use them in longitudinal monitoring studies. And then at the end of the day, you get a protocol printed out from your CTG, which analyzes the basal fetal heart rate, decelerations, accelerations, episodes of high variation, low variation, and the short-term variation. And this is very important. So then we performed the Truffle-1 study that concentrated on early fetal growth restriction, and we wanted to find out what is the optimal time of delivering those fetuses with early fetal growth restriction. And the second question was, or the main question, does the ductus venosus help us in estimating the optimal time for delivery? Now, inclusion criteria were fetuses with early fetal growth restriction defined as AC below the 10th centile, an increased umbilical artery PI, because we wanted to make sure that this is a placental disease, estimated fetal birth weight above 500 grams at the entry of the study, gestational age at enrollment between 26 weeks and 32 weeks, because we wanted to make sure that these are viable fetuses already. And the short-term variation had to be normal at study entry, of course. That means 3.5, higher than 3.5 milliseconds between 26 and 29 weeks, and more than 4 milliseconds between 29 and 32 weeks, because there's an increase of short-term variation with gestational age. And of course, there had to be a normal ductus venosus waveform, because that was exactly one of the parameters we wanted to test. The primary outcome, and this is very important, was normal infant neurological outcome based on Bailey score assessment at the age of 2 years. So the infants were investigated with a Bailey score at the age of 2 years. And therefore, of course, we could only do this investigation in surviving infants. And this is important. I will tell you later different results. The secondary outcome was survival analysis. Of course, mortality was also investigated by a group of composite neonatal morbidity and mortality and infant mortality. Now, there were 3 groups according to randomization. Group 1 was the CTG group, short-term variation. As I said, had to be normal at the time of inclusion. In this group, it was only allowed to look at the umbilical artery, and ductus venosus ultrasound investigations were not allowed. And then we had the 2 ductus venosus group. Number 1 is the early fetal ductus venosus changes, which means an increased pulsatility, an increased PI value, but still positive flow during atrial contraction. Whereas the late ductus venosus group showed the most severe abnormality of the ductus venosus, which was reversal, zero flow or reversal of blood flow during atrial contraction. Now, it's very important. The part of the package for indications for delivery was a safety net as well, which was valid irrespective of randomization arm. And for the early ductus venosus group and late ductus venosus group, we had this safety net, which indicated delivery if short-term variation fell below 2.6 milliseconds between 26 and 28 weeks, and below 3 milliseconds between 29 and 32 weeks. This limit was lower than the short-term variation in the CTG group, because it was a safety net for the ductus venosus group. Furthermore, for all 3 groups, regardless of short-term variation, regardless of ductus venosus changes, unprovoked spontaneous decelerations were an indication for delivery. Umbilical artery Doppler reverse end diastolic flow was an indication for delivery at the latest at the beginning of 32 weeks. It was permitted already from 30 weeks onwards, and absent end diastolic flow after 34 weeks, respectively after 32 weeks, and maternal indication like severe preeclampsia or HELP syndrome or whatever. Now, this study was published in The Lancet in 2015. The results of this study, you may be aware of them, but the most important I will summarize here. First of all, for the whole group, more than 500 pregnancies, you could see, and this is typical for early fetal growth restriction, there was a high incidence of any hypertensive maternal morbidity, more than 70%. Delivery indication before 32 weeks occurred in 71% of these fetuses. Birth weight, the mean birth weight of all these fetuses was about 1,000 grams, and gestational age at delivery was around 30 weeks plus 5 days. Now, let's look at the outcome at 2 years. This was for the overall group, not differentiating between the different randomized groups. For that one, you see 503 cases, and 363 of them survived without impairment. There was a loss of follow-up of 12%, so 88% were followed up, and there was an incidence of 41 cases, which is 18% of perinatal death, intrauterine fetal death, perinatal death in terms of neonatal death, and then up to the age of 2 years, 8%. Now, if you look at the percentage of evaluated surviving fetuses, so this was the Bailey score at the age of 2 years, 90% was normal, 90% was normal. This was much higher than in any previous observational study at that early gestational age. And if you look at the percentage of all infants with known outcome, of course, this includes the mortality, all the pregnancies which ended in mortality, it was 82%. The cerebral palsy rate, only 1%, was much lower than in all the previous observational studies. And now this is the most important slide you can see here. Now the truffle outcome with survival without impairment for the three groups was significantly different between the CTG group and the late ductus venosus group. It was 85% in the CTG group, survival without impairment, but it was 95% in the ductus venosus group. Of course, a lot of these cases with the late ductus venosus changes had to be delivered because the safety net gave the indication for delivery earlier, before the ductus became severely abnormal, and also maternal indications, but you should wait until the ductus becomes abnormal. If we include all the fetuses with known outcomes, so this includes mortality as well, there was a trend, but it was not significantly different. So you can see here, in terms of perinatal survival with normal neurodevelopmental development, you should wait for late abnormalities in the ductus venosus, but you have to take into account the truffle protocol with the safety net, which applies also as an indication for delivery, and that you can decrease neurodisability. You may have to accept a little bit a higher perinatal death rate, but that was not significant. Now, what are the implications for early fetal growth restriction according to the truffle findings? Before 32 weeks, management should be based on ductus venosus, lower risk of neuroimpairment if delivery is based on absent or reversed A wave, or if the CTG STV is severely abnormal. Always use both CCTG and ductus venosus. Don't wait until both are severely abnormal, and deliver if the umbilical artery becomes severely abnormal after 32 weeks, at the latest if there is reversal of flow, and after up to 34 weeks at the latest if there is zero flow. What about the UC ratio, cerebral redistribution? This is part of truffle 2. And this is the next step. There's just a few slides that just give you an insight into the study protocol of truffle 2 because that's on its way. So this is for late fetal growth restriction after 32 weeks. Now, first of all, we had this study which was published recently in the White Journal, where we looked at fetal cerebral Doppler changes and outcome in late preterm fetal growth restriction as a prospective cohort study. And you could see that fetal cerebral Doppler changes were found to be associated with adverse perinatal outcome. Now, the important term is here associated. It's not a causality, it's an association. And we confirmed this association with this study, but whether cerebral flow changes are a marker of fetal compromise and whether intervention of changes and whether an intervention changes the risk for poor outcome can be answered only in a randomized intervention trial. You can see here the incidence of the composite adverse outcome in 856 late preterm singleton pregnancies at risk of fetal growth restriction according to Z-scores, gestational age, and birth weight. You can see that, of course, it depends on gestational age. The earlier you deliver a baby, even with late fetal growth restriction, the higher is the incidence for major neonatal morbidity. And the same is true for an increased Z-score in birth weight. However, if you look at the data of 584 pregnancies which had Doppler measurements obtained within 1 week before delivery, 1 minute left, thank you, that's good. With Doppler measurements obtained within 1 week for delivery, you can see that the UACR ratio had also clearly an association which was significant with the composite adverse perinatal outcome. So it's worth to look at the middle cerebral artery. And this is the protocol for the truffle group, for the truffle 2 study. And the PICO is as follows: recruitment between 32 and 36 weeks plus 6 days, and then plus cerebral redistribution or a fall of more than 50th percentile drops will be the reason for, or the indication for delivery in the study group, according to the UCR ratio, different between 32 and 33 weeks, and then 34 and 36 weeks, of course. The intervention is delivery. The control group is no cerebral artery Doppler, just umbilical artery Doppler, and short-term and computerized CTG. Await until the short-term variation falls below 4.5 milliseconds, or there are unprovoked decelerations. And the outcome will be short-term mortality, morbidity, and 2-year BAR score. This is a questionnaire which is sent out to the parents, and they should send back then. Okay, I forgot to press the button. So here you can see all this what I have told you, Pico. Randomization takes place. If they are randomized to immediate delivery, they have to be delivered or induced within 48 hours. After administration of steroids up to 34 weeks, of course. If they fall into the group with delayed delivery, Doppler and CCTG twice a week at last, but middle cerebral artery Doppler is not allowed, and delivery is indicated when short-term variation falls below 4.5 milliseconds on CCTG, or there are repeated decelerations. And this is my last slide. Sometimes I need to simplify my life to the point where all I think about are the next 20 feet, not the next 20 years. And this is exactly what we have to do if we do the monitoring, especially in early fetal growth restriction. We have to do it every day. And maybe tomorrow we have to decide to deliver. But for the follow-up studies, we have to think for the next 20 years to make long-term follow-up studies in these fetuses, or children then and adolescents. Thank you very much for your attention.
Thank you, Dr. Kurt, for a very interesting and informative lecture. Now we have time for 1 or 2 questions. Dr. Sharif.
Thank you, Professor Hecher, for an excellent presentation. I'm afraid if we don't have computerized CTG in our department, how can we optimally manage early cases of severe IUGR before 32 weeks? If we don't have computerized CTG, can we rely solely on the abnormality of the ductus venosus?
Well, first of all, I mean, clearly, if you don't have it at the moment, you cannot compare the monitoring strategy, what we have used now for the truffle study. But you can look, of course, and you do look for repeated unprovoked decelerations, because this was part of the safety net as well. And you look at the umbilical artery Doppler, and I mean, at the end of the day, you should buy a computerized CTG. Yeah. It is not that expensive. It's much less expensive than an ultrasound machine. So therefore, I think in every high-level perinatal center, there should be a computerized CTG available for these or for these pregnancies. Thank you.
Thank you very much.
Any other questions?
But of course, you can do the Doppler, and you should do the Doppler. Look at the umbilical artery and the ductus venosus.
Now, is any role to sildenafil in the management of fetal growth restriction? Is there any role for sildenafil or Spatio in the management?
Sorry?
Role of sildenafil or Spatio in the management of fetal growth restriction. Is there any role now in the management?
For early fetal growth restriction or late fetal growth restriction?
For early.
You mean the intervals between? We don't use it. No, sildenafil, forget it. We don't use it. It should be only used in prospective studies. The problem is, but there is this randomized study is out already. And as far as I know, there were different results in different countries. For instance, it was stopped, I think in the UK, or was it in the Netherlands? It was stopped in the Netherlands. It was stopped due to an increase of intrauterine fetal death, which others could not see, like in the UK or in Australia. But it should only be given any medical any medical therapy or pharmaceutical studies should be performed as a controlled randomized study.
Okay, thanks so much.
Thank you.
I have just one further question about medical treatment, because this is something we've seen a lot of here in Egypt. When you have a diagnosis of early severe IUGR, you find a lot of obstetricians using low molecular weight heparin as a method of treatment. What do you think about that?
You mean aspirin?
No, the low molecular weight heparin. Low molecular weight
Heparin. No. There's no use for heparin. It has never been shown that it helps.
Okay. Any other questions?
No.
Oh.
Heparin only if there was a premature delivery with preeclampsia and with a small baby, yes.
Yeah.
But not for growth restriction
Not for
per se. Oh, but that is for aspirin and not for heparin.
Okay, thank you, Dr. Kat.
Okay,